I'm just here. I'm glad everybody came tonight. I always try and give a few of these talks a year. I'm just here to shed a little light on most foot conditions, and we focus a little bit on bunions and so forth tonight, but we'll cover all the topics, and I'll answer a lot of questions at the end. And so whatever questions you may or may not have, feel free to shoot, and that's okay. There's no hesitation here. A lot of it is just I'm trying to bring a little awareness of what differences there are in the foot and ankle community in terms of treatment options. A lot of people just don't know, and there's a big spectrum between podiatrists and how they treat it, and orthopedic surgeons how they treat it, and I try and shed a little light on that tonight. So again, thanks for coming out, and let's see what we can learn tonight. So about the bunions, again, we'll start off with those. The medical perspective in terms of a history and what I hear from patients, there's usually pain on the inside of the great toe. It's usually with a certain type of shoe, generally a constrictive shoe, and it generally hurts worse when people are on their feet. And a lot of times people come with not only just pain on the bump or the inside aspect of the great toe, but it's also an arch pain. On exam, we see the foot looks pretty normal. There's usually a red protuberance at the great toe. Everybody have seen this with the bunion, grandma's bunions or a cousin's bunions. It's usually right on the inside of that ball of the big toe. There's a little swelling. It's usually tender to touch, but everything else seems pretty good. On X-ray, you see words like an increase in the inner metatarsal angle and hallux valgus, which is the medical terminology for bunion. Every patient who comes in says one or two things. I've worn high heels my whole life, and that's what's caused it. The other thing is, does this mean I can't wear cute shoes anymore? And we always laugh, and I try to describe it at the end. So, in the scheme of things, what is a bunion? What causes a bunion, and what do we do for a bunion? There are a few theories on it. We don't know exactly what it is. Many theories exist, but the idea that I subscribe to is the idea that, whether you believe in evolution or not, there's a transcendence of bipedal gait. Basically, if you look at our ancestors, if you look at chimps or gorillas and so forth, they will walk on their feet a little bit, but not a lot. Their feet are still mostly like hands. And so from that standpoint, if you look at this picture on the far right, that is the hand of a chimp, and this is the foot of a chimp, and this would actually be the big toe over here. And so the idea is that the entire inner aspect of this chimp's foot is very loose because it still grabs branches and so forth with that. In addition to that, you take the looseness of the arch and you take a calf muscle that is never really meant to touch the ground, and now all of a sudden with humans, the calf and the heel is meant to touch the ground, and all of a sudden we've got some tightness issues coming up. So the bottom line with all of that is we base it a little bit off of evolution. The second, probably the most important part, is the calf muscle tightness theory, where the calf muscle is really a shock absorber to the foot. Picture the calf muscle in the back here, and it forms this Achilles tendon that attaches to the heel. It acts as a spring or a shock absorber to the entire foot. So the more pressure you put on the ball of the foot, the more you want this calf muscle and the Achilles tendon to act as a spring. The tighter the spring is, the less the front of the foot springs upward. So what we see is that the people with the tighter calf muscles put a lot of pressure on the balls of their feet and their arch, and the people with the loosest calf muscles put almost no pressure on their arch. And so if you look at the studies out, the people with the loosest calf muscles, and that's just the way you're born, are less prone to foot injuries or foot pain, and the people with the tighter calf muscles are more prone to bunions and hammer toes and arch collapse and tendonitis and arthritis and all of those. So every person who comes in with a foot issue almost guarantee that they're going to have a tight calf muscle, and that's just the way they were born. So that's kind of the second theory. Here's a perfect and classic x-ray of a bunion. This is looking down on the foot. This, of course, is a right foot. These are the balls of the toes here. The toenails would be way at the tip, and these are all the little arch bones here. A bunion, as you see from this x-ray, this is a big bump on the inner aspect of the ball of the big toe. There is no growth of bone here. It is simply this bone that leads to the ball of the big toe having angled more toward the inside of the foot. This angle stems from the area in the arch getting a little loose. So the easiest way to look at it is this should be here covering these two little circle bones, and over the course of time it's drifted this way, and that's what causes this big bump. It's not that there's a growth of bone here, the whole bone itself has shifted, and that stems from this area because this has to be loose for this bone to angle that way, and that's what happens. The question is, why does it get loose or why does it angle? That goes back to, well, some people are just a little looser in the inner arch, and some people have really tight calf muscles that beat up that arch and stretch out those ligaments and allows the bone to move over. So two important causes, the tight calf muscle and the loose arch. What are the treatment methods here? The first thing we always try is to stretch the calf muscle out. That goes for almost every single foot and ankle problem. We always address the calf muscle. It is the root of all evil. Everybody who has a foot issue will have a tight calf muscle. If we can stretch that out, people will feel a little better about it. This goes with bunions too. Anti-inflammatories. The easiest part is, look, if it's swollen or if it hurts, it must be inflamed. So we give a little anti-inflammatory to take the edge off. It can't cure all those bones and make the bone shift back in place, but it can sure make it feel a little better. And then we try and modify the shoes. Maybe you wear a shoe with a little wider toe box. You wear a small heel. Heels, a small heel that is, 1.5 inches, 2 inches at the most, generally is more comfortable than a flat shoe. So if you look at most people with foot issues, a shoe with the small heel is going to suit them better. That men are a little limited because they don't have a whole choice in shoes except for maybe like a cowboy boot or a clog or something like that. So men are a little more women. Women have a million choices in shoes with the small heel. And then the softer the upper part of the shoe, the more forgiving it is. People always ask, well, I read this magazine on the airplane that had this fancy strapping apparatus, and it was meant for bunions. Does it work? It doesn't work. It can't do anything. All it does is give you blisters and cause you difficulty with shoe wear. So don't worry about those straps. Don't wear them. They don't make a difference. So what if we try all that and it doesn't help? Then you're looking at the fix for the bunion. You're still having pain. You've tried stretching. You've tried the shoes. You've tried the anti-inflammatories. No good. The first aspect we combine with every bunion fix, and this goes along with a lot of the foot issues, we first make a tiny incision. You can see it's probably about 1 inch to 1.5 inches long. And where up high on the calf muscle, there's a band of tissue. And that band of tissue we can retract, and all we do is snip that band of tissue. It pulls apart. Over 6 weeks, it grows back together, and it's a new, longer band of tissue. All that means, it doesn't weaken you, it doesn't change your calf shape. All it does is it makes your foot spring up a little easier, which takes the pressure off the arch, which takes the pressure off the ball of the foot. That's the first thing we do for every bunion. The second thing is we have got the x-ray on the left, again, is you can see how this bone is swung way over. It's way out of shape. We need to get the whole bone moved back over. The difference here is that, as you can see on the right, this is after surgery. We have pushed the whole bone over and we've put 3 screws in. 1 screw is here, 1 screw goes this way, and 1 screw goes this way. We have moved that whole bone back over and we're holding it there with 3 screws. This is a little a little hammer toe work that's a little different, but this is the main culprit to get the bunion moved back over. That is a permanent fix for it. It fuses it in the right position. It can't move back over, and it stabilizes the arch. What we see in the different treatment methods, and here in Central Illinois, it is a huge podiatry market in terms of bunions. They treat bunions a little differently. You'll see the mainstay for a type of bunion they're dealing with. They'll cut underneath the ball. They'll shift the whole ball over and then pin the ball in place. And so when it heals into a curved bone. Our thinking as an orthopedic surgeon is, why would you take a deformity and create another deformity to correct the deformity? So you're compensating for a deformity by creating another deformity, which doesn't make a whole lot of sense. It doesn't address the looseness of the arch, and it doesn't address the calf muscle. That's why if you look in the literature, you'll see 7, 8, 10, even 15 years out, people's bunions, people think they grow back. Well, they don't grow back. They just continue to progress even though that bone is banana shaped, it just continues to go. And so consequently, you see the people returning, and what's the fix for it? Well, you move the whole bone back over and you put those 3 screws in to hold it into place. That's kind of the fix for the bunion. Here's another bunion. Again, on the side, you can see the big bump right on the inside of the ball of the big toe. These are the balls of the lesser toes. And these 2 little circle bones, we need those covered up by this, what we call the first metatarsal, or the big toe bone. So what did we do? We moved the whole bone over to cover those 2 circle bones and held it in place with 3 screws. Again, a permanent fix. It addresses all the problems. We did the calf muscle with it. We stabilized the arch, and we've corrected the bunion. And we did not create another deformity with it. Why can we stiffen up that joint without any consequences? That joint was never meant to move in the first place, and over the course of time, that got looser and looser and looser, and that's what caused the problem. So all we're doing is making a joint that was never meant to move, not move. And that's the way to look at it. Here's another one on the left foot. Again, we see a big prominent ball on the inside. Again, there's no growth. It's just the bone has drifted because of this joint. We need to move it back over. 3 screws, we hold it in place, and you can see it's nice and straight, and the bunion is then gone. So it certainly addresses the heart of the bunion. Post-operatively, we're looking at a splint, which is kind of partial plaster. It's not a full cast for 2 weeks. After 2 weeks, we check the incisions. You're non-weight bearing on this, meaning you can put a little weight on the heel for pivoting and balance, but you can't put any weight on the ball of the foot. After 2 weeks, we get the sutures out, and we check the incisions, and then you go into a boot, and you treat basically the boot like a cast in order for those screws to hold things in place. Therapy and weight bearing and strengthening and everything begins at that 6-week mark. People ask, well, what's the overall progression of healing? Well, 3 months, everybody's walking, they're using a regular shoe, but they're still a little weak, they're a little achy, they're a little swollen. That very common. A lot of times and this is very common with most of these foot surgeries, the bigger ones at least. We call that the 3-month blues, where people just aren't quite happy and they feel like they should be further along at 3 months. But when you just can't put a lot of weight on your leg for 6 weeks, you lose a lot of strength, you lose a lot of calcium in the bone, and all of that needs to be built back up. And that's what you look at. So 3 months, okay, but not great. 4 months for these bunion procedures, most people are standing again, their swelling is gone, and the achiness is much better. So you're going to devote a good 4 months to getting over these bunion fixes. If you look at bigger surgeries like ankle fusions or ankle replacements or extensive arch fusions, you're looking more around the 6 to 9 month mark when people really start to turn the corner and feel like they've gotten their strength back and are doing a lot better. So definitely a time commitment, there's no doubt about it. Here's an example. So here's one surgery where you've got, again, the bone that's loose at this joint, swings over to the inside, and you've got this very prominent inner bump, as it were. First surgery, they tried to cut the bone and shift the bone over, and they put this little plate and screws on top of it. And at first, it looks pretty good. The 2 little circle bones here are now covered. Not bad. If you look at it about 2 years later, you can see the whole thing has slid back over, and you see the little circle bone here completely uncovered again. So what it's doing is still drifting because the joint that was loose was never addressed in the first place. They tried to cut the bone, move it over. What we would do is instead of just trying to cut the bone or move it or put a plate and screws, we move everything over, and we hold it there with screws, so it's more of a permanent fix. This is, you'll see it done very infrequently, aside from my treatment method, and that's, again, my treatment method is to move everything over and put the screws in. If you've had people who've had bunions done, almost guaranteed it's going to be where they've cut one part of the bone, tried to move the bone over, and held it. And that's why you talk to people, bunions are very, can be unreliable in that. The smaller bunions, sometimes you can get by with that treatment, but anything that's a medium or a large bunion is very difficult. But my treatment method is a little different than what most people are used to, and that's that really is the difference what I try and bring to the community. And like I say, I try to bring just an awareness of that there's a difference, and there's a huge spectrum in foot and ankle surgery. I mean, If you take just the two fields of podiatry and orthopedic surgery, that's different. And then you can start to subdivide the differences in orthopedic surgeons, how they treat things. And so that's why it's probably once a day while I'm in the office that I get somebody saying, I was told never to have foot surgery. What do you think? I'm like, well, I am a surgeon. Let me see here. So I don't have to ham and haw. But, that's why I try and describe people. I understand why they get that impression. And there's no easy way to allay their fears about that. All I can tell you is that here's the difference. This is what I'm going to do. And it's different than probably what you're used to or what Uncle Joe had or Aunt Edna had. It's just different. And so just keep your minds open to any of that if you're really thinking about something. It never hurts to get a second opinion. It never hurts to just talk to someone else because, again, it's not that any one camp is right because everybody, obviously I'll be biased to the orthopedic camp, but podiatrists are very biased toward their camp, and that's just the way they're trained. So you could go across to Indiana or Michigan, and podiatrists are doing the same thing. So it's not that they're wrong. It's a different treatment method. And so it's just knowing that options are out there. So just a few other slides about what else we can do. A lot of people it's an often question that people say, well, I've been wearing this brace for 10 years and they told me nothing could be done about it. And sometimes that's the case, but many times it's not the case. There's always a surgery to be done, and my goal, from your standpoint, is to give you the predictability of it. Is this going to be a high success rate surgery, or is there going to be a low success rate surgery? But there's always a surgery out there. If you're such poor health and we don't think you're going to make it, or we think that the complication rate is too high, then we say surgery is probably not a good idea. But it doesn't mean a surgery is not out there for you, put it that way. Some people look at me and go, I can't live like this. I am going to take my chances at whatever surgery it is, and we're going to go ahead and do it. It's there. It's just we have to know what we can expect and what we're worried about. I always tell people, this is what I'm worried about with your foot. And some people come in, I'm not worried about anything. And you just kind of take the standard things as it comes and you kind of deal with it. But some people come in and I've already got beads of sweat coming down my forehead because some people just are really poor candidates. And so that's what we're doing. But that's why I try and show you today a couple little things that we can do. So here is an example of a really, really flat foot. And there are a million flat feet people out there, and almost everybody can make it through their entire lives with intermittent bouts of foot pain here and there. We can usually get over the hump. And some people finally come in their 60s or 70s and go, oh my God, I've had enough. This thing's been hurting me for 5 years. I made it through my whole life. I can't do it. What can we do? This is an example of an x-ray where the person waited so long that they actually walked on a dislocated foot. So we took this and we put as many screws in there as we could, and we realigned the whole arch, essentially fusing most of the little joints in that arch to hold it in place. And people say, my God, well, she's not going to be able to walk. She'll walk like Frankenstein. Well, that's not the case, because if you take the person who needs this extensive of fusion, they're already walking so poorly that the lack of pain, or the majority lack of pain afterwards, and the more stable foot they have, they're walking more normally than they have in the last 10 years. So, yes, they have limitation in motion, but if you go back to their state for the top x-ray, they had no motion in their foot anyway. So the fear is always, what am I going to lose if I do it? And the answer is, you've already lost it. You're not losing anything. Here's another one where still kind of a low, it would be still categorized as probably a severe flat foot, but it's certainly not as bad as the previous one. And here again, a little less extensive a fusion, but plenty of screws in there to hold that arch up. And you can see how it just brings all those bones up a little higher. Again, a permanent fix for it, and the balance of the foot is now there. It's just a stable arch and a stable foot. Here's an example of a bad ankle. Normally, if you look here, this is the inside ankle bone, and this would be the outside ankle bone. And this little black line here is the cartilage, or the ankle joint. And this should be nice and symmetric. And you can see here, it's bone on bone. Here you've got a little cartilage remaining, but it's bone on bone here. And they've been dealing, that doesn't happen overnight. It's years in the making. And so they come in, they say, well, what can we do about it? This person was a candidate for an ankle replacement. So essentially, we cut out the arthritis on the end of the shin bone, and we cut out the arthritis on the foot bone. We put metal in the place, and that little white gap in between is actually plastic. It just doesn't show up on x-ray. So you've got plastic in between two metal parts, just like a knee replacement or just like a hip replacement. The only difference with these ankle replacements is that there's the percentage of people who are candidates for is way narrower than a hip or a knee replacement, because the ability to go back in and redo an ankle replacement, meaning if it wears out or if it fails quicker than what we'd hope, the ability to redo that is very limited. So we have to choose our patients very wisely in terms of what's the arthritis look like, how heavy are they, do they smoke, do they have diabetes. All these factors play a role in whether it's going to be predictable or not to do it. Some people say, I want the ankle replacement or not. They might be bad candidates. And I would tell them, look, I'll give it to you, but you've got to know that this thing might not last 5 years for you, and that's the risk. Much narrower window than, still a great procedure, and the people it works for it, they love it. It's a great procedure. We just have to choose our patients very carefully. Here's another ankle replacement, different variety. I do 2 different types. This one just has a little bigger stem. This was a person who was in a horrible car accident. They had all these plates and screws and broken everything, and their ankle went on to arthritis. So again, this one has a big stem that goes up into the shin bone, and it has a plate here, and basically a plate here, and in between is the plastic. So again, just like a knee or a hip replacement, just in a different part of the body. Here again, bone-on-bone arthritis. Inside ankle bone is over here, outside is over here, and the little joint line is right here, bone on bone. This person, here's another ankle replacement. So we put the metal on the bottom, metal on the top, and in between is the plastic. Here's one where we've got a person who had bad ankle arthritis in the front. The toes would be way out here, and this is that ankle joint. You can see there's a little gap here, but in the front, bone on bone. And so we tried to save that ankle joint before fusing it by cutting the heel bone and doing a little balancing act in the front of the arch, and that rebalances and takes the pressure off that ankle. So even before we can fuse an ankle, we can still balance the foot under it. The foot is the foundation for the ankle, and sometimes we can save that ankle for another 5 years just by doing a procedure on the foot. And again, this is I don't mean to sugarcoat this or make it seem like a small procedure, any of these small procedures, but again, there's a lot to do out there that people aren't exposed to sometimes. Here's a terrible condition where this person basically, people get neuropathy, which is a disease of the nerves. A lot of times diabetics get this. Their bones will sometimes disintegrate and the joints fall apart, and that's exactly what this person had. So we had to reestablish the arch because those people start to walk around, they get ulcers on their feet. Well, the ulcers can lead to infection. Infection leads to amputation, so we have to do everything we can early on to build that arch up again. So this person, we had to lift all the bones back up and put as many screws in as possible to hold it. Again, those are all fusions. The ankle joint still works, and they can walk very normally. Is it stiffer than a normal foot? Of course, but the alternative is a functionless foot that's just waiting for an ulcer. So here we take the chance, we do it, and this patient did quite well. Here's another person where you can just see the saw line. They had a terrible ankle fracture, and they actually healed this in a what we call a malunion. It was just at an angle. So what we did, we cut the outside leg bone, we cut the end of the shin bone, and we took a big wedge of bone out and closed it down, and we held it in place with a big plate on the outside, and we put all these screws through the plate to heal, and then this little saw cut heals together. But now the ankle, as you can see, that little ankle joint is now flat to the ground, and that's what we're going for. That's a major surgery. Here's another one. This man is he was a different type of neuropathic. He underwent some type of ankle surgery for a fracture. It fell apart. His whole joint dissolved, and he was stuck going, well, do I amputate it or do we try and fix it? And so what we did, we put a rod right through the bottom of the foot, ran it right up the shin bone, and all this bone healed back in. So he was able to walk, and again, very stiff, but the alternative was a prosthesis. Here's a lady, congenital deformity, lots of surgeries in the past. We took both joints, the upper ankle joint and the lower ankle joint, and we put as many screws in there as we can to hold it together. Again, if you looked at this one, very painful, inability to walk any distances. You take this, you stiffen her up, there's no question, but now her pain level is so much less that she feels a lot more comfortable with walking and gait and so forth, and she'll tell you she's the happiest person alive to trade a little stiffness for all that pain. Here's a, we deal with a lot of fractures. With my group in the Springfield Clinic, we take the majority of the trauma call, which is the high energy fractures you see in car accidents and so forth. And I'm the foot and ankle specialist. I do almost all the lower extremity fractures, and at least concerning the ankle and the foot. And so we get a lot of just, I mean, for lack of a better term, mangled feet. They've got breaks everywhere. And our job is to reconstruct these to give the bones back their shape in order to come back and be able to do something down the road for further surgery. If you don't fix it right in the first place, then guess what? Coming back later is almost impossible. So this is an example of a foot that was broken about in 12 places. It's got breaks everywhere, and half the bones are dislocated. This is just a high energy injury to the arch. And so what we did, we put plates, pins, screws, wires, everything we possibly could in there to reestablish the arch. Now I can come back in a year or 2 years, take all of that metal out, and I can fuse the joints that get arthritic. But if we don't rebuild it just right off the bat, then the foot's never quite normal. So again, they might always still have a little pain. We can't take away all the pain because I can't make it a perfect foot. But we can make it a lot better foot, and that's the key. And I'll tell you, there's a lot of the techniques to do this. My training's focused specifically on this, and you'd have to, a lot of training entails you going to a place that sees a lot of the high volume and high energy accidents, and that's exactly what I was able to train in. So that's part of the other thing I bring, these complex foot fracture reconstructions. Here's another one where it's the end of the shin bone. This is broken to about 10 pieces. This would be the outside ankle bone that's broken. High energy. I know it's a little difficult to see, but our goal was to put this thing back together. And so we put 3 plates on it, rebuild it, and then the ankle joint's right down here. The ankle joint looks pretty good. If they get arthritis in it, the bone is back in perfect position, so we can come in and do an easy reconstructive procedure down the road if and when they get arthritis in it. Here's one, the terrible one. Where I trained in Seattle, we had a lot of people who, I don't know if it was because of the weather or not, but there was a high suicide rate in Seattle. And there was this one bridge in particular that people tried to jump off of, and what they don't realize, there's surface tension. The water is so strong that when they hit, it's just like hitting concrete. And so we had a lot of jumpers. Well, this person broke their calcaneus, or their heel bone, and every one of those wires is basically holding a piece of bone together. And that's how many pieces was in. So what we ended up doing was putting a plate, screws, and fixing both the talus bone and the heel bone in order to give this person a shot at a normal foot. Now again, they're going to get arthritis in it. Our goal is not to prevent arthritis. Our goal is to reestablish the normal anatomy of the foot, and then we can come back at a later date and do those fusion procedures we saw earlier. So in summary, just as an overall recap, the bunion, not just a bump. Bunion, there's a whole different treatment strategy out there. There's a huge variation on treatment strategies, and just remember, it's not a growth of bone, it's not a bump, it's a lot more than that. Tight calf muscle, root of all evil. If you have foot pain, you have a tight calf muscle, and so start stretching, and we'll start addressing it that way. There's a different, I bring a different bunion treatment method. It's a higher success rate, lower revision, and again, it's permanent results. And all foot and ankle problems have solutions. It's all about predictability, and that's my job to tell you about it. When you can't take any more, you've tried everything. What are going to be the odds of your success? And that's my job to tell you how well it's going to be out. But there's always something out there for someone. So thanks again. I'll take any questions you guys have about any part of the foot or the ankle, or anything else if you really want. I just might not be able to give you a straight answer on it. How's that? Yeah, right in the back.
I had seen you once for an appointment about ankle fusion.
Yeah.
And does the calf stretch, will that help the arthritis?
The
calf surgery, where you loosen or cut that tendon, or?
It's a good question. what you'll find is that we don't have a lot of conservative, meaning non-operative treatment for arthritis. It means the cartilage is gone. You've got a very bad cartilage or very little cartilage remaining, but almost guaranteed by the time your cartilage has gotten that bad, your calf muscle has tightened, or maybe it started out tight. Sometimes if there's enough cartilage left, we can go in there and do a little calf lengthening procedure, clean up some bone spurs, and sometimes it does give people a little relief. The downside to arthritis is no surgery that fails to address the arthritic issue of it, meaning the cartilage issue, means that you're still going to have pain. So maybe we could make that better with a certain surgery, but until we actually address the cartilage, you still have arthritic pain. And that's the downside, unfortunately.
It's just that you're off work for so long.
That's right. And
there's a problem.
If you're a sit-down employee, you're back in about 3 weeks. That's the beauty of having sit or retired. But if not, it is a time commitment, and ultimately some people wait till they retire. Some people say, I can't deal with it anymore, I've got to do it, and they bite the bullet. But you're not doing any harm by waiting. That's the bottom line. Yeah.
Hammer toes, you never got into that.
Oh yeah. Hammer toe is the easiest way to look at a hammer toe. It's any clawing of the toe. You can call a claw toe, you can call it a hammer toe. It all depends on what joints bend and so forth. There are a lot of causes for hammer toes, but the main, if you kind of poll everybody's had a hammer toe, a lot of people will get their knuckles, the knuckles that are bent, cut out, and a pin that's run right down the knuckle. And half the time the knuckle doesn't fuse, and the toes can drift a little bit. My take on hammer toes is that, sure, I do the pitting procedure also, but there are procedures out there where you can just rebalance the tendons of the toes. You can still weight bear on them. You don't have any pins, any metal, and you can get by very easily with it. That generally works very well in the hammer toes that are still flexible, meaning I can hold it, straighten it out, and it can straighten. Some people's hammer toes are so bad that the knuckle will not straighten. Those are the ones that, the other thing I bring that's a little bit of a difference is I can put a screw right down the middle of the toe and hold it there. And that screw is buried. And you get to walk on that afterwards. A lot of the pins will loosen or the pins fall out. They don't hold it very securely. So the bottom line is that hammer toes are very correctable, but there's a lot more than just one type of solution to a hammer toe.
Well, I broke a hammer toe. Mm-hmm. And they did surgery on it to straighten it. Mm-hmm. And now it grows bunions or calluses on the side of it.
Yeah.
I wanted to cut out the big toe, and I kind of backed off.
It happens. You know, if that knuckle happens to drift around that wire, you get buildup of bone, you get scar tissue around it, and it starts to rub a little funny. We do go back in there and what we call revise hammer toes. Less predictable. It gets a little tricky sometimes. But a lot of times we go in there, we can straighten out a hammer toe and make that alleviate some of that pain. So it's definitely an option to go back in there. And it's not just a wire again. It's not just, we can put a screw, we can balance the tendons, we can do all kinds of stuff. Then addressing the big toe. So definitely options out there for you. Yeah.
What can you do for plantar fasciitis?
Oh, sorry. I think it's right behind you. Yeah, sorry. Okay, I'll do you next. How's that? Plantar fasciitis, that's basically the bottom of the heel and slightly to the inside. It's a burning pain. The natural history of this, 9 to 12 months, it finally burns out and goes away. It's an inflammation of a big rope of tissue on the bottom of the heel. We throw everything at it that we possibly can. And the majority of people, say 90% of people, it'll be gone by 9 to 12 months. It's about stretching the calf muscle. It's about icing the bottom of the foot. It's about taking anti-inflammatories if you're allowed to, like Aleve or ibuprofen or something stronger. Arch supports are a great idea. The women can wear the shoes with the heel. That actually helps a lot with the heel pain, believe it or not, just a small heel. And then we do cortisone injections. Cortisone injections hurt. They're probably the most painful painful injection you can get. But a lot of times it can get you over the hump. What I tell people, if we get the perfect strategy for plantar fasciitis, our hope is that we just speed it up. We can't make it fast, but we can hopefully make it shorter than 9 or 12 months. And that's what, there's no simple fix for it. We get some people who come in who are out, say, 18 months or a year, 18 months or 2 years out from having plantar fasciitis. They've tried everything, multiple cortisone injections, they've stretched, and they cannot get it better. They've tried every insert under the sun. A lot of times we'll do a little calf lengthening procedure on them, and it will make that heel pain a lot better, a lot better. So still options for the people who suffer with it for years. Right here.
I asked my foot doctor about if they had ankle replacements like knee replacements.
Yes.
And he said that they did, but they hadn't been turned out to be too successful. Have they gotten better or?
It depends what he was talking about in terms of ankle replacements. The older varieties, they weren't terrible, but they certainly didn't have the success rates. Right now, what I tell people is that if you look at the longest studies we have, if we've got a good candidate for surgery, meaning the patient is suited for the surgery, you're probably going to get about 9 or 10 years out of the ankle. The hope is that at the end of 9 or 10 years, it hasn't failed catastrophically. Maybe the plastic's worn a little bit, maybe we have a little bony cyst here or there, maybe we've got a little spur formation, and maybe we just need to, for lack of a better word, we need a tune-up. And a lot of times that's all you need with an ankle replacement. So you tune it up and then you're back on your feet again. It's the ones that you can't predict that wear out after 5 years or 6 years, and it's not just a tune-up you need a complete redo. Those are the ones that are much more time involved. But again, that's not the common procedure for those to fail. Most of the time they just kind of, they need that little tune-up and that's it. So if the person is of the right age, meaning if you put in a 50-year-old, it's definitely going to wear out. If you can get somebody in their 60s or their 70s, that's a perfect age. If the weight is down, they don't have diabetes, and they've not smoked or they're not smokers, those are the people we look for. So kind of the small person, not super active, but again, not inactive. And again, I put them in younger people, and you look at them and they say, well, I don't want my ankle fused, I want it replaced. And you just say, look, this thing might wear out after 8 years or 5 years, or it just we might not get the full 10 years on it. And they say, well, I'm willing to take that risk. And that's fine.
And I tell them sometimes that it's in my ankle bone that hurts. And he says that I have tendonitis, and it's the tendons that cause the ankle bone to hurt. Mm-hmm. Is that?
I don't know. I don't know about that one. I'd almost have to see your tendon and see if it was hurting. Generally, tendons don't cause the bones to hurt. So I don't know about that one.
Having had hammer toe surgery, also having had bunion surgery on the same foot, I'm finding that the little toe is giving me an unreal challenge in that it is twisting and turning out, and it is painful. I'll admit to you that I've gone to a podiatrist, because my medical doctor said... Everybody has. That's his recommendation, and it was new, and I've had the bunion and the hammer toes probably 12 years ago, the bunion and the hammer toes 10 years ago. So this toe that's twisting on me now and creating a lot of discomfort. I did get those King shoes, which have the wide, and that gives me the room and comfortableness. But what about trying to fix that little toe, plus the one hammer toe here next to the little toe? It is extremely distorted looking from that surgery, and I'm not a real happy camper with the end result.
Yeah.
What can be done about that?
The pinky toe is an easy fix. A lot of times if we just rebalance the little tendons, no pins, nothing like that, very straightforward. We can rebalance. That's a 10-minute surgery.
He told me nothing but probably a steel beam in there, or a little wire or something. It's going to be there, and I'm not going to have any flexibility.
Yeah, you wouldn't have to do that.
Cool.
Yeah, a different option. The other toe that's already been operated on, I'm the first one to admit hammer toes are very difficult, and I always talk to my patients about that. Some hammer toes look very straightforward. Some you go in, you say this is going to be a home run, and then 3 months later you're looking at the patient, they're looking at you like, what happened? And you're like, I don't know what happened. So a lot of times it's just these little toes can be finicky. Going back in for them, I do it, but when I warn the patient, I say, if we're going to redo a hammer toe, you have to make sure it really hurts, because going back in there with all the scar tissue, those little arteries that supply the toe probably are less than half the size of pencil lead. And so if anything happens or the scar tissue kinks up, we lose probably half a toe. And some people look at me and go, I'd rather have half a toe than the toe I have now. Let's do it. And that's obvious. I mean, but if you look and go, well, it's bad, but it's not that bad, I probably would not recommend going in to redo a hammer toe. But there are surgeries out there to redo it. You could either do a screw right down the center of the toe, you could try to repin it, or you could try just a tendon procedure. So definitely options, but you've got to make sure that you're prepared that the predictability goes way down the second time around with a hammer toe.
Can you explain exactly how a hammer toe, how that happens like you did with the bunion?
Yeah. Oh, in terms of what? Well, let's see if I can find that one little picture. It's all about the middle knuckle of a toe, that it becomes a little tight. There we go. So this gentleman, he had the bunion, and the whole bone moved over. You've got the ball of the second toe, and then the hammer toe. His hammer toe actually crossed over, so he basically dislocated the joint, moved the toe over. So what we try to do is take the toe, the second toe, which is here's the ball of the toe, of the second toe here. We take the toe itself, we moved it back over. You cut out the knuckle, so it's just bone on bone, and we want that little knuckle to fuse. We don't need to bend our toes like claws. We just need to push them downward. So not being able to flex your toe, that's part of the hammer toe world. I mean, you just don't get to. I had one lady I did hammer toes. They were perfect. I mean, spot on perfect. And it's hard to get perfect hammer toes. And she said to me, but I can't pick up socks anymore with my toes. Sorry. But so the whole purpose of the pin is to hold the toe straight. And this pin actually goes into the ball of the second toe. And it holds it nice and straight, and over the course of 6 weeks while that pin's in, it basically fuses up the knuckle of that hammer toe. So the knuckle can't bend anymore, but a hammer toe is when the knuckle actually bends up. So if you cut the knuckle out, straighten out, and it fuses, it stays straight. So that's what a hammer toe is about. So here's the perfect example of a pin. We could take the pin out, do the exact same knuckle procedure, and just put a screw right down the middle of it, right down the center of the bone. They're buried, it's under the skin, you can't see it anymore. So that works out very well too. The really flexible ones that just kind of pop up, but I can straighten them out very easily, we just rebalance the tendons. Rebalance the tendon. Take the bottom tendon, transfer it to the top, lengthen the top tendon, and all of a sudden the toe's resting comfortably. Again, can't bend it like a claw, but you can pull it down. That's all we need to do. If we have to do the screw, if it's still flexible, you're walking on it, you wear a little hard sole shoe for 2 weeks. Very straightforward. So very easy. Yeah.
I just had an experience with a blood blister on my big toe. And I want to know what causes it and what can you do to prevent it?
What part of the big toe?
It was on the outside of the big toe, and it was the length of the toe. And it took me 4 weeks to get rid of it.
My first guess is that you could have had it could have been a hot, sweaty day, or you could have built up a little sweat in the shoe and it probably abraded a little bit on an insert.
Okay.
Or the shoe itself didn't breathe very well. That could have caused it. Or were you doing an activity that you normally don't do, like walk a great distance or anything like that?
Okay.
Anything out of the blue that you did?
Well, not really. I was doing some landscaping, but that was it, you know.
So it could have been simply, we don't landscape every day. It may have been the way you were pushing off, and if you had a little sweat in there too from landscaping, that it probably just caused a little friction, and there's your blood blister. So you might think about a different change of shoes, or maybe putting on a little foot powder before you start something like that.
And also, I read on the internet that you're not supposed to take and puncture a blood vessel.
Right.
You're supposed to take and put some kind of anesthetic on it finally bust itself.
That's right.
Correct?
That's the easiest way to do it. The sooner you break it open, it's very fresh and it can introduce bacteria and then you get a little infection. So we don't want to do that. So just keep it covered and let it kind of declare itself.
That's what we did.
Yep. Perfect.
Thank you.
No problem. Yeah.
Regarding bunions, do you make it worse if you wait too long for the procedure?
No. Bunions progress very slowly. And does it make me work a little harder if you wait way too long to do it? Yes, but they're all correctable. They're all correctable, especially with this type of procedure. The bigger a bunion gets, if one person is only used to doing the smaller procedure where you kind of cut the bump and move it over, big bunions don't do well with that surgery, period. They do terribly with it. So for that, if you're only going to do that surgery, then you can wait too long. But from my standpoint, you can never wait too long because I can undo the biggest bunions because we're correcting it from the very essence of where it started. So the answer is no from my standpoint. Yeah.
Is that true with hammer toes too? If you really, that's not a problem, right?
Little bit of a difference. So hammer toes, if they just curl upward and they stay straight in line with the foot, I don't think you can wait too long. If they start to dislocate, and some people wait that long, the whole joint gets so broken down that the toe will actually dislocate back toward the arch. Then when you straighten them out, a lot of times you can kink the little arteries to the toes, and then we're looking at a big problem where you might not be able to correct it. The other issue with the hammer toe is a lot of times they don't just draw up in line with the foot. Sometimes they cross to the left or cross to the right. We have a lot more difficult time correcting side-to-side hammer toes. So if you notice that the toe is bothering you and it's starting to drift to one side, I would probably fix it sooner rather than later before it got too out of whack, because the ones that come in and they're pointing 90 degrees the wrong way, I tell people after surgery, it's still probably going to point a little bit in that direction. As much as we can possibly fix it, we just can't pull it side to side like we'd like to.
Do you ever just do the cutting of the calf and no other surgery, just if there's a minor problem with the bunion or hammer? Getting worse?
Generally not for bunions or hammer toes. We do it in isolation. We do just the calf muscle procedure in isolation, a lot of times for chronic heel pain, Achilles tendonitis, pain under the balls of the feet, diffuse pain in the arch where maybe they have a little arthritis but not a lot and they don't really need a big arch procedure. If we do the calf procedure and take a little pressure off the balls of the feet or off of the arch or off of the Achilles tendon, all of a sudden people could feel a lot better about it. So again, not 100%, but that's a 10-minute surgery that you get to walk on, so it can be very powerful and make people feel a lot better about it. Yeah.
If you have a hammer toe bunion on the same foot, but you can't afford the time to correct the bunion, can you fix the hammer toe and it won't get any worse because you're not fixing both?
Good question. So the question was, if you have a bunion and a hammer toe, can you just fix the hammer toe because it's a lot quicker fix?
And
The
you're
answer-
not having time
Right.
taking care of a senior mother that I can't not walk
Yeah.
for a long,
Right.
And I don't want to say once she's gone, I can come in and do it.
No. I get it. I understand. And there are a lot of people with this. I mean, just with work alone, some people just can't take the time off. The answer is yes, you can go in and fix the hammer toe, but if you don't fix the bunion, it's a lot less predictable. Meaning you might go through this hammer toe procedure, and we might have to redo it. And as you know, going in there and redoing a hammer toe, not very predictable. So my recommendation is always, I would probably use a strap or something like that for the hammer toe, because they do have straps for hammer toes that can help, but I probably would not recommend going in after it just in isolation.
Okay.
Yeah.
Do it at the same time.
Yeah, most predictably. Yeah.
That was going to be my next question,
Yeah.
the strap
Mhm.
for a hammer toe. You do recommend that?
Especially for the flexible toes, the ones where the knuckle is so tight you can't straighten out the knuckles, straps do not work. But the ones where the hammer toe is still pretty flexible, even if they have a little stiffness, they have little straps that you can pull the toe down and holds it straight, they work fine. I mean, it's not correcting anything with the hammer toe, it's just holding it out of the way so it doesn't rub on the shoe. So, yeah, you can do it that way. I don't know if CB, they have different types of straps, so certainly you could try just a pharmacy to get these little hammer toe straps, and they'd probably be able to guide you. If you didn't have any luck with that, you'd come in and see me, and I'd get you one. That's easy enough. Sure. Yeah.
I have osteoarthritis, had it for several years, and I've gone to see a couple podiatrists, and the thing about podiatrists and orthopedic surgeons having different views on things that fascinates me a little bit. But of course, I went to the podiatrist first because those orthopedic surgeons, you go to their office the next day you're having surgery. But
I wish it worked that way. I'd be the happiest guy alive. I don't know what I'm doing wrong.
The treatment I'm getting is working for the most part. It's not as painful as it is when I'm not doing anything. But is there a fix for osteoarthritis?
What part of your foot or your ankle?
Between the tarsals and metatarsals, that joint, that area.
So kind of right in the middle of the arch.
Yeah.
Arthritis, the bottom line is that you've got cartilage problems. The cartilage is narrowing and the joint is getting closer to bone on bone. That's arthritis. That's the same in the knee. It's the same in the hip. The cartilage is not good anymore. It catches, it burns, you get bone on bone, and you just don't have that smooth surface. You can try cortisone injections. You can try arch supports. You can try bracing. You can do all kinds of things to help support arthritis. But you're not doing anything to actually change the cartilage or the joint until you go in there and do surgery. So the answer is no, we don't do any, there's nothing to do. I mean, arthritis it's on its own path. And it's only got one way to go, and that's worse. And it's usually a slow progression. But you can try to accommodate symptomatically, meaning make your symptoms feel a little better until you just can't take it anymore.
But at some point, you can use the screws and stuff and
Absolutely.
Together.
Oh yeah, absolutely.
Okay.
No problem. We do that all the time. We just take those arthritic bones in your arch, fuse them together because you don't want those arch bones to move. And whatever caused those arch bones to move and get arthritis, we cinch them together and you're done.
And the podiatrist has told me that they can do anything for pain, but I have numbness in the center toes, and so we can't do anything for numbness. Can an orthopedic surgeon do something for numbness?
We make the appointment.
That's right.
For both of us.
That's right. Numbness is a hard part. Neuropathy, numbness, it's all the same thing. The nerves just are not functioning correctly. I'm not quite certain why you'd only have it in one toe. We'd have to kind of come up with
the three center toes, and he explained it was the certain nerve that goes between one of the bones or something, and it's being cramped.
I see. So, it depends on how long you've had a situation like that where a nerve might be pinched or so forth. A lot of times, if you fix the arthritis and kind of build the arch back up and take the pressure off of it, you can undo that damage to the nerve. If it's been there long standing for years and your toes are just completely numb, chances are we're not going to do anything for it. But again, the plantar, the bottom aspect of the toes is where we need sensation. You don't have to have it, but it's very helpful. So, if you step on a thorn or something sharp, that definitely can make you feel, that's where we want to focus on it. Top of the toes, top of the foot, sensation is almost meaningless except for it bothers people. Yeah.
This may not be an appropriate question to answer, and I understand if you do not know it. If you've been to a podiatrist and now you want to go to orthopedic, what's the insurance going to say?
Nothing. No problem at all.
No challenge.
There will be no challenge.
Okay.
Yep. Yes.
Talking about numbness up there, the balls of my feet, I touched my right foot, I have that problem. It's probably not really numbness, that's the best I can describe it, but it's more closer to pain, but I hesitate to call it pain. But I've had that for years, and I was told to do the, stretches of the calves, and that really does seem to keep it under control. But it's better and worse,
Yeah. What I tell people, if the stretches are working, keep doing it. If you don't do surgery, you don't introduce any extraneous complications. That's the idea. So if it works, I can't improve on something non-surgically that's working. I can't improve on that with surgery.
It doesn't, what surgery do you do for it?
Well, we have some people who come in and if the foot is balanced in a certain way where it's reasonable and you're just having pain under the balls of the feet and you've tried arch support and stretching and anti-inflammatories and all these things, we can do just the calf lengthening procedure and it would take the pressure off the balls of the feet. Some people have a really loose arch and it overloads some of the balls of the feet. There, it becomes too unpredictable to do just the calf. Sometimes you have to stabilize part of the foot and do the calf procedure with it.
Are you familiar with race walking?
With what?
Race walking?
I am not.
It's a certain type of walking, it's competitive walking.
Oh, you said race.
Race walking.
Okay, yes. I thought you said grace at first. I'm like, I don't know, grace walking. Gracefully? Yeah, race walking, yes.
Is there any problem with that for foot-wise?
No, it's still a low impact way to running is much, much higher impact. So race walking is fine. You're still putting the same amount of impact on your foot as walking. You're just doing more steps.
You flex your foot hyper, more than you do when you're running.
Mhm.
It's constant.
It won't. It's the impact that we find makes the most difference on a foot. The beating up and the impact, it really plays the biggest role. So that should not. Sure.
Just in the future down the road, is there any chance there's going to be any type of laser treatments for these types of problems?
Boy, the all-present laser. Boy, if lasers could solve everything we thought they could. Even now there's, they try and say, bony-wise, I see no treatment for lasers, at least not in the next 10 years. People are trying to do laser treatment for toenails, and even if you look at the studies on that, it's not great. If you look at one study, it's good, and the next study, it's not good. So lasers right now have not really been proven to be that effective in any part, and I don't see that changing anytime soon. No more, that's it, that's too easy. I wanted the hard ones.